Welcome back to KMR Advice for another deep dive. Today, we're focusing on a really fundamental group of medications, ones you'll see used across almost every medical specialty. We're talking about diuretics.
Yes, exactly. And this discussion on diuretics, it's specifically designed for you, our medical students here in India. Our goal today is really to build a strong, structured understanding. We'll look at, when we use them, how they're classified, precisely how they work, their mechanisms, and some of the really important clinical points,
Yeah.
especially things relevant to your future practice right here.
Exactly. We want to break down this essential info in a clear way, something memorable, so you feel confident when you encounter diuretics. Think of it as maybe a shortcut to really getting them. And if you find this deep dive on KMR advice helpful, please do share it with your classmates. Subscribe to the channel for more content like this, and definitely hit that bell icon so you don't miss any of our future discussions. Okay, so to start us off, let's unpack the many different situations where we actually use diuretics. Where do they fit in?
Right. So diuretics are key in managing a really wide variety of conditions. But maybe the most common one is edema, that swelling that happens because of fluid buildup. Now, it's important to remember, edema isn't a disease itself. It's more of a sign, really, of an underlying issue. So we see cardiac edema when the heart isn't pumping effectively, like in congestive heart failure, CHF. Then there's renal edema. That can happen in conditions like chronic kidney disease, CKD, or maybe nephrotic syndrome. And finally, hepatic edema. You see this in patients with liver problems, most notably cirrhosis. And actually a really important point here, especially thinking about liver cirrhosis causing ascites, that fluid in the abdomen. Spironolactone is often the first diuretic we reach for. That's a key one.
Right, that's a crucial distinction, especially for us Witzes. Okay, and moving on to hypertension, high blood pressure, diuretics are pretty central there too, aren't they?
Oh, absolutely. For, let's say, uncomplicated cases of hypertension, thiazide diuretics are frequently the initial treatment, the first step, often. But they also have a role in managing those more challenging cases, like resistant hypertension.
And what about patients who have kidney problems and high blood pressure?
Good question. When we're treating hypertension in patients who also have kidney issues, specifically renal insufficiency, we often switch. We tend to use loop diuretics in that situation.
Okay. And you mentioned emergencies earlier.
Yes. What's particularly noteworthy, maybe even life-saving, is the role of intravenous loop diuretics. For furosemide, for instance, in acute pulmonary edema, that's when there's a sudden, severe buildup of fluid in the lungs, a real medical emergency.
Right. And brain swelling, cerebral edema.
For cerebral edema, swelling in the brain, mannitol is typically our preferred drug. It's an osmotic diuretic, though sometimes we might use furosemide alongside it as an adjunct. So you see, even just within managing edema, the choice of diuretic depends heavily on what's causing it and how urgent the situation is.
That makes sense. It gets interesting, though. Diuretics aren't just for fluid overload and blood pressure, right? There are other uses.
Exactly. They have some other, maybe less immediately obvious applications. For instance, hypercalcemia. That's when there's a dangerously high level of calcium in the blood. Administering loop diuretics with saline helps the kidneys get rid of that excess calcium, lowering the levels.
And kidney stones. I remember something about that.
Yes, surprisingly, for people who tend to form calcium-based kidney stones, thiazide diuretics can actually be helpful. They reduce the amount of calcium that's excreted in the urine, which can help prevent future stones.
Okay, so reducing calcium excretion there. And you mentioned ascites again.
As we touched on, for ascites, particularly when it's from liver cirrhosis, spironolactone remains a really important part of the treatment plan, often the go-to.
Glaucoma, eye pressure.
Right. Lastly, while it's less common now because we have more targeted eye drops, carbonic anhydrase inhibitors like acetazolamide were historically used. They help manage glaucoma, the condition affecting pressure inside the eye. So yeah, a really diverse set of uses, all stemming from how they influence fluid and electrolyte balance in the body.
Okay, so diuretics clearly have a pretty broad range of uses, all tied to fluid regulation. Now, to understand why different diuretics work in different situations, let's talk classification. How do we group these drugs? What are the main categories?
Sure. We generally group diuretics into 5 main classes. And this classification is based mostly on their mechanism of action, like how they work in the kidney and the specific part of the nephron, the kidney's functional unit, where they actually do their job.
Yeah.
So these 5 classes are loop diuretics, thiazide diuretics, potassium-sparing diuretics, carbonic anhydrase inhibitors, and osmotic diuretics. Understanding these categories helps us predict not just how effective they'll be, but also what potential side effects we need to look out for.
That makes a lot of sense. Grouping them helps organize things. So let's take a closer look at each class. Can we go through some specific examples? Especially ones our medical students here in India will see, maybe including some common brand names.
Definitely. Let's start with the loop diuretics. These are known for being very potent. They cause a really significant increase in urine output. Common examples you'll definitely see are furosemide, often known by its brand name Lasix. Then there's torsemide, marketed as Ditor, and bumetanide, or Bumet. Now, something really important for our Indian students to note, torsemide, disomider, is increasingly becoming the preferred loop diuretic over furosemide for managing chronic heart failure. That's a trend in many centers across India.
Why is that?
Better absorption, longer action, maybe better compliance with once daily dosing. We'll touch on that more later. Also, bumetanide might be used if a patient's response to furosemide isn't quite strong enough.
Okay, good to know about torsemide.
Hmm?
Moving on to thiazide diuretics then. You said they're a mainstay in hypertension.
Yes, exactly. For thiazides, we have hydrochlorothiazide, often found as Esidrex. There's chlorthalidone, known as Thalidone, and indapamide, which you might see as Natrolix. A key point to remember here is that chlorthalidone is generally considered more potent, and it works for longer than hydrochlorothiazide.
Longer action, more potent. Okay.
Right. And also, indapamide is very, very frequently used in combination pills for hypertension here in India. You'll often see it paired with other blood pressure drugs.
Got it. Combination therapy. Next up are the potassium-sparing diuretics. The name itself gives a clue, right?
Exactly, it does. Examples here include spironolactone or aldactone, eplerenone, known as Eptis, and amiloride, or Amifru. One important difference. Eplerenone tends to cause less gynecomastia, that's breast enlargement in men, a potential side effect of spironolactone.
Oh, right. That can be an issue.
It can. But eplerenone is generally more expensive, and spironolactone, as we've already said, is really important for managing ascites.
Okay. Then we have the carbonic anhydrase inhibitors. Sounds a bit different.
Yeah, the main one here is acetazolamide, often sold as Diamox. It does have some diuretic effect, but using it just for edema is quite rare now. You're more likely to see it used for glaucoma management, or sometimes for preventing and treating acute mountain sickness. So its main uses are kind of outside routine fluid overload these days.
Right, more specialized uses. And finally, the osmotic diuretics.
For osmotic diuretics, the key examples are mannitol, brand name Osmotrol, and glycerol, or Glerol. Mannitol is particularly important in critical care. You'll see it in ICUs, neurosurgery for increased intracranial pressure, and also in certain situations in nephrology.
Okay, so that's a good overview of the 5 classes and some common names we'll encounter here. Now that we know the who's who, let's dive into the how they work. Their mechanisms of action, right down at the kidney level.
Understanding the mechanism of action for each class is absolutely fundamental. Let's start again with loop diuretics. Their main site of action is in the thick ascending limb of the loop of Henle, hence the name loop diuretics. They work by specifically inhibiting the NAO-CAR2-skilo transporter. That's a channel in the cells lining this part of the nephron.
The NAK2CL co-transporter.
Okay, exactly. By blocking that transporter, loop diuretics significantly cut down the reabsorption of sodium, potassium, and chloride back into the bloodstream. And because sodium and chloride are key players in water movement, stopping their reabsorption leads to a major loss of both salt and water from the body. That results in a really potent diuretic effect. Lots of urine.
Potent effect, okay. And how do thiazides compare? Where do they work?
Thiazide diuretics work a bit further down the nephron in the distal convoluted tubule, or DCT. There, they specifically inhibit a different transporter, the NIO-CLO symporter. Blocking this stops sodium and chloride reabsorption in this segment. This leads to a more moderate level of diuresis compared to the loop diuretics. Not quite as strong, but still effective.
And didn't you say they affect calcium too?
Yes, that's an interesting point. By affecting this NANCL symporter, thiazides also indirectly cause less calcium to be excreted in the urine. They increase calcium reabsorption, and that, as we mentioned earlier, is why they can be helpful in preventing those calcium kidney stones.
Okay, that connection makes sense now. And the potassium-sparing diuretics, they sound like they have a different target altogether.
Yes, they do. Potassium-sparing diuretics work way down in the collecting duct. That's the final segment of the nephron before urine leaves the kidney. There are basically 2 main ways they work, spironolactone and eplerenone. They are aldosterone receptor antagonists.
Aldosterone antagonists.
Okay, right. Aldosterone is a hormone that normally tells the kidneys to hold on to sodium and water, but get rid of potassium. By blocking aldosterone's receptor, these drugs do the opposite. They increase sodium and water excretion, but help the body hold on to potassium, hence potassium sparing.
And the other type, amiloride.
Amiloride works differently. It directly blocks the epithelial sodium channels, often called ENAS, in the collecting duct. This also reduces sodium reabsorption, and as a consequence, it also reduces potassium excretion. So same potassium-sparing outcome, just a different direct mechanism.
Got it. Two ways to spare potassium. Now, how about osmotic diuretics like mannitol? Their mechanism sounds completely different.
It really is. Osmotic diuretics like mannitol work based on, well, osmosis. When mannitol gets filtered by the kidney's glomerulus, it's not easily reabsorbed back by the renal tubules. So you have this substance, mannitol, stuck inside the tubule. Its presence increases the osmolarity, the concentration of dissolved stuff inside the tubule fluid.
So it makes the urine more concentrated, basically.
Inside the tubule, yes. And that higher osmolarity acts like a magnet for water. It draws water into the tubule lumen and prevents it from being reabsorbed back into the blood. The result is just more water staying in the tubule, leading to increased urine volume. And because mannitol also increases the osmolarity of the blood itself, it can pull fluid out of other places like the brain, which is why it's useful in cerebral edema.
Pulling water out of tissues, too. Okay, finally, let's quickly revisit the carbonic anhydrase inhibitors, acetazolamide.
Right. Carbonic anhydrase inhibitors like acetazolamide work mainly way up in the proximal convoluted tubule, right after the glomerulus. They inhibit the enzyme carbonic anhydrase. This enzyme is crucial for reabsorbing bicarbonate ions. By inhibiting this enzyme, these drugs reduce bicarbonate reabsorption, so more bicarbonate gets excreted in the urine.
And that causes diuresis?
Well, sodium reabsorption is linked to bicarbonate reabsorption in this segment. So blocking bicarbonate reabsorption leads to a mild increase in sodium excretion and thus mild diuresis. But this mechanism also messes with the body's acid-base balance, leading to metabolic acidosis. That really limits their long-term use just as diuretics.
Okay, that's a really clear breakdown of how each class works, right down at the nephron level.
Excellent. Now that we understand the how, let's think about the when and how long the pharmacokinetics. How quickly do they work? How long do they last? Yes, exactly. Understanding pharmacokinetics helps us predict onset, duration, and how the body eliminates the drug. Crucial for dosing. Let's start with furosemide Lasix. Orally, it usually starts working within, say, 20 to 40 minutes. Intravenously, 4V, it's much faster, maybe 2 to 5 minutes.
Very quick, Avi.
Very quick. Its effect generally lasts about 3 to 6 hours, and it's mainly eliminated unchanged by the kidneys. A key Indian clinical note here. We often use IV furosemide in emergencies for that rapid effect, and then the oral form is fine for longer-term maintenance.
Okay. What about torsemide, diphenor, especially given its increasing use in chronic heart failure here?
Right. Torsemide has a slightly slower start compared to IV furosemide, maybe around an hour when taken orally. But its duration of action is significantly longer, typically 8 to 12 hours.
Longer lasting.
Much longer. And it's primarily metabolized by the liver, then the metabolites are excreted by the kidneys. A big clinical advantage, especially in India, is that it's suitable for once daily dosing. That really helps with patient adherence, especially for chronic conditions.
Once a day is definitely easier.
Okay. And clothalidone, the thiazide noted for potency in hypertension.
Clothalidone has a relatively slow onset, maybe 2 to 3 hours to start working, but has a very long duration of action, sometimes 24 to 72 hours.
Wow, up to 3 days.
Yeah, it hangs around. It's mainly excreted by the kidneys. Clinically, that once daily dosing and really long effect make it a preferred thiazide for long-term hypertension management.
Makes sense. Let's also touch on spironolactone aldactone, given its role in ascites. Spironolactone is quite slow to start. You might not see its full effect for 2 to 3 days. Its effects also tend to last for a couple of days after stopping it. It's eliminated through both the kidneys and the liver. A crucial Indian clinical point. When using spironolactone for ascites or heart failure, we usually start low, a low dose, and then gradually increase it as needed. And careful monitoring is essential.
Start low, go slow. Got it. Finally, mannitol, used in critical situations.
Mannitol has a rapid onset 4V, and its diuretic effects usually last about 6 to 8 hours. It's excreted entirely by the kidneys. Because it can cause really big fluid shifts, very strict monitoring of the patient's fluid status and electrolytes is absolutely essential, whether they're in the ICU or even on a general ward. Strict monitoring.
Understanding these timings and durations is so vital for picking the right drug and dose. Okay, let's switch gears to something really important, the potential downsides, the adverse effects of diuretics.
Yes, Absolutely critical. Like all meds, diuretics can have side effects we need to watch for. We can group these based on the type of imbalance they cause. Think about electrolyte imbalances, metabolic effects, problems from losing too much fluid volume depletion, ototoxicity, which is hearing related, and some endocrine effects. And often, understanding these side effects comes right back to knowing the drug's mechanism.
Right. The mechanism predicts the problems. And can you walk us through some specific examples in each category? Let's start with electrolytes.
Certainly. Electrolyte imbalances are quite common. For instance, loop and thiazide diuretics, they often lead to hypokalemia low potassium. On the flip side, potassium-sparing diuretics, as the name suggests, can sometimes cause hyperkalemia, high potassium. Hyponatremia, low sodium, can also occur with various diuretics. It happens because these drugs directly change how the kidneys handle these vital electrolytes.
And how do we manage that?
Management involves careful monitoring, checking blood tests regularly, and often it requires giving potassium supplements if levels are low, or maybe adjusting the diuretic dose, or even stopping the drug if potassium gets too high.
Okay. What about metabolic effects? You mentioned those.
Yes, diuretics can sometimes affect metabolism. For example, they can lead to hyperuricemia, increased uric acid in the blood. In people prone to it, this can trigger a gout attack. They can also sometimes cause hyperglycemia or high blood sugar, maybe by affecting insulin release or sensitivity.
So, gout and high blood sugar, what do we do then?
Well, if hyperuricemia is a problem, we might need drugs like allopurinol. For hyperglycemia, it's mainly about careful blood glucose monitoring, especially in diabetic patients.
Right. And volume depletion seems like a very direct consequence of drugs that make you pee more.
Exactly. It's a primary effect. Yeah. Because diuretics push out fluid, losing too much can lead to a drop in blood pressure, hypotension, and also dehydration. Symptoms can range from just feeling thirsty or dizzy to more serious confusion or fainting. Management usually involves adjusting the diuretic dose, finding that sweet spot, and making sure the patient drinks enough fluids.
Okay. Now, ototoxicity, damage to hearing. I remember learning that's linked to one class particularly.
Yes, you're right, loop diuretics, especially when given IV, and particularly if given too quickly or in very high doses. They have the potential to cause ototoxicity. This might show up as tinnitus, ringing in the ears, or even actual hearing loss. The exact mechanism isn't perfectly clear, but it seems to be a direct effect on the inner ear.
So we need to be careful with IV loops.
Definitely. Be cautious with the infusion rate, especially with high doses, and always ask patients about any new hearing problems.
Good tip. Lastly, you mentioned endocrine effects.
The most notable one here is gynecomastia, breast tissue development in males. This can happen with spironolactone. It's because spironolactone also has some anti-androgenic properties, meaning it blocks male hormone effects.
And if that happens, is it reversible?
It often is if the drug is stopped. If it becomes really bothersome, sometimes switching to eplerenone, which has a much lower risk of causing gynecomastia, is an option, though cost can be a factor.
It's really important for our listeners in India, our students, to know about any specific clinical notes on side effects relevant here, isn't it? Are there particular things to watch out for?
Absolutely. In the Indian context, we sometimes see perhaps overuse or inadequate monitoring with loop diuretics. It's crucial to be extra vigilant for hypokalemia and dehydration, especially in our elderly population or those in rural settings who might have less consistent access to follow-up and blood tests. They're particularly vulnerable.
That's a really important point about access and vulnerability.
Yes, and also because spironolactone is used quite a lot for ascites and heart failure, we must be extra careful monitoring for hyperkalemia, high potassium. This is especially true when it's used together with other drugs that also raise potassium, like ACE inhibitors or ARBs, which are common blood pressure meds. That combination really bumps up the risk.
Okay, ACE inhibitors, ARBs, plus spironolactone equals high hyperkalemia risk. Got it. These are really crucial points for practice in India. Now let's shift gears. When should these drugs absolutely not be used, or used only with extreme caution? Let's talk contraindications.
Right. We think about absolute and relative contraindications. Absolute means the risk is just too high, don't use it. This includes anuria, when the kidneys aren't making any urine at all. Giving a diuretic won't help and could be harmful. Also, severe electrolyte depletion that hasn't been fixed yet. Giving a diuretic would just make those imbalances worse. And of course, a history of a serious allergic reaction, a hypersensitivity to the drug itself. Also, remember sulfa allergy that can be a contraindication for both thiazide and loop diuretics, as they are structurally related to sulfonamides.
Okay, so anuria, severe electrolyte issues, allergy, a sulfa allergy, those are absolute no's. What about relative contraindications? When do we need to be extra careful?
Relative contraindications are situations where you might use them, but you need to weigh the risks and benefits very carefully and monitor closely. This includes gout, as we mentioned. Diuretics can sometimes trigger attacks by raising uric acid. Diabetes mellitus, because they can sometimes affect blood sugar control, requires closer glucose monitoring. And pregnancy. Particularly for loop and thiazide diuretics, their use should be cautious and generally only if really necessary, and the benefits outweigh potential risks.
Okay, use with caution in gout, diabetes, pregnancy. It's also vital to understand how diuretics interact with other medications, right? Drug interactions.
Hugely important. Drug interactions are a major area to consider. For example, NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen or naproxen, they can actually reduce the effectiveness of most diuretics.
So painkillers can stop diuretics working as well.
Some common ones, yes. Also, as we just touched upon, using ACE inhibitors or ARBs together with potassium-sparing diuretics significantly increases the risk of dangerous hyperkalemia. Loop diuretics can increase the risk of ototoxicity, the hearing damage, if they're given with aminoglycoside antibiotics like gentamicin.
Another ototoxicity risk. Okay.
And lithium, a drug used in psychiatry, its levels can go up, potentially causing lithium toxicity, especially when loop or thiazide diuretics are used at the same time. They reduce lithium clearance by the kidney. And finally, digoxin, a heart medication. If diuretics, particularly loops and thiazides, cause hypokalemia, low potassium, this low potassium increases the risk of digoxin toxicity.
Wow, lots of potential interactions. So, taking a really thorough medication history from every single patient is absolutely essential before starting any diuretic.
Absolutely non-negotiable. You need to know everything else they're taking.
Okay, let's move on to some practical stuff.
Right.
Typical dosage ranges for key diuretics and maybe some clinical pearl practical tips for our students.
Sure, knowing typical doses is fundamental. For furosemide, Lasix, oral or IV, usually 20 to 80 milligrams, maybe once or twice a day. But for severe edema, doses can sometimes go higher, maybe up to 200 milligrams a day under supervision. Toracimide, Dizarter, often preferred now for chronic heart failure in India, typically 5 to 20 milligrams orally once daily. For hypertension, clothalidone is commonly used at 12.5 to 25 milligrams orally once a day. Spironolactone, aldactone, for heart failure or ascites, generally ranges from 25 to 100 milligrams orally per day. Remember, start low, titrate up. And for acute cerebral edema, mannitol is IV only, dosed based on body weight, usually 0.25 to 2 grams per kilogram.
Okay, those are good starting points for doses. And what about those clinical pearls? Those really practical tips students should remember.
Okay, here are a few key ones for practice in India. First, you'll see a growing trend of using clothalidone and indapamide in combination pills for high blood pressure, often combined with drugs like amlodipine or telmisartan, very common now. Second, it is absolutely critical, cannot stress this enough, to regularly monitor serum creatinine for kidney function and potassium levels in all patients on diuretics, especially those with other health problems or taking multiple meds. Regular blood tests are essential.
Monitoring, monitoring, monitoring.
Got it. Exactly. And finally, patient education is huge. You need to clearly explain the signs and symptoms of dehydration, things like increased thirst, feeling dizzy, peeing less often. Also tell them about potential muscle cramps, which could signal electrolyte problems like low potassium. And always stress the importance of regular follow-up appointments and getting those blood tests done. Communication is key.
Excellent pearls. Now, what if we suspect a patient is having problems? Diuretic toxicity. What signs should we look for and how do we manage it?
Recognizing toxicity signs is crucial for quick action. If a patient develops unexplained muscle weakness, palpitations, or any heart rhythm irregularities, immediately think hypokalemia. Check their potassium level and give potassium supplements if it's low. Severe dehydration might show up as a big drop in blood pressure, confusion, or extreme dizziness. This often needs treatment with intravenous fluids, IV fluids.
Okay, IV fluids for severe dehydration. What about hearing issues?
If a patient reports new tinnitus, ringing in the ears, or any hearing loss, especially after starting a loop diuretic, suspect ototoxicity,
Mm.
you might need to stop the drug if appropriate and definitely get an audiology evaluation.
And gout attacks.
A sudden severe gout attack could be triggered by diuretic-induced hyperuricemia. Management might involve drugs like allopurinol or colchicine, depending on whether it's acute treatment or prevention.
Got it. Are there any specific black box warnings we need to absolutely know about or any final keynotes?
Yes, a couple of important black box warnings. For spironolactone, animal studies showed a potential tumor risk, though it's not definitively proven in humans. But we must closely monitor for hyperkalemia. That's a definite risk. Loop diuretics also carry a black box warning. Because they are so potent, there's a significant risk of causing profound diuresis, too much fluid loss, leading to dangerous electrolyte imbalances. So close clinical and lab monitoring is essential with loops.
So black box for spironolactone, tumor hyperkalemia, and loops, profound diuresis electrolyte issues. Any other key takeaways?
Yes, just to reiterate, chlorthalidone is generally considered more effective and longer acting than hydrochlorothiazide for blood pressure control, and it's often preferred in current Indian hypertension guidelines. And also remember, mannitol is strictly IV, intravenous only, and it requires very careful monitoring of fluid balance and kidney function because of risks like fluid overload or even acute kidney injury if not managed perfectly.
Okay, IV only for mannitol, strict monitoring. What would you say is a really high yield fact, something particularly relevant for our Indian medical students to lock in?
A very high-yield fact, especially relevant here in India, is that torosmide, Ditodor, is increasingly being considered the preferred loop diuretic over furosemide, Lasix, for the long-term management of chronic heart failure in many cardiac centers across India.
And why again?
Mainly due to its better, more predictable oral absorption, its longer duration of action allowing once daily dosing, and some evidence suggesting maybe a lower risk of causing hypokalemia. This can all add up to better overall effectiveness and better patient compliance.
That's a really crucial point for practice here. Okay, finally, as our listeners gear up for exams, what's on your final exam checklist for diuretics? The absolute must-knows.
All right, final exam checklist. Number 1, mechanism of action for each of the 5 classes. Know the nephron site, know the transporter or channel they hit. 2, know the key drug examples in each class and which ones are typically first line for specific conditions like thiazides for hypertension, loops for acute pulmonary edema, spironolactone for ascites. 3, major adverse effects. Really know about electrolyte imbalances, hypo and hyperkalemia. Know about ototoxicity with loops, gynecomastia with spironolactone. 4, essential monitoring. What do you need to check? Renal function, creatinine, electrolytes, especially potassium, sodium, maybe uric acid. And finally, number 5, clinical application. Be able to apply your knowledge. When would you choose a loop over a thiazide? When might a potassium-sparing drug be risky? Think about patient scenarios. Excellent checklist, really covers the core concepts. So as we wrap up this deep dive on diuretics here on KMR Advice, we've certainly covered a lot of essential ground. We've highlighted just how fundamental these drugs are in managing so many conditions you'll see in your careers here in India. Absolutely. We've emphasized those current considerations, like the preference for toracimide in chronic heart failure and clothalidone in hypertension here. And we've really tried to stress how critical it is to understand the mechanisms, know the side effects, and follow the monitoring rules for safe and effective use. Couldn't agree more. And maybe a final thought for everyone listening. Always remember to look at the individual patient. Consider their specific history, their other conditions, what other medications they're taking. That personalized approach is key, and it will help guide your choices beyond just the general guidelines we've talked about today. Well said. And with that, we encourage you to revisit this discussion on KMR Advise whenever you need a refresher. If you found it valuable, please do share it with your colleagues, your fellow medical students. Subscribe to the channel for more medical education content tailored specifically for you, and don't forget to hit that notification bell so you stay updated. Thanks for joining us. Thanks, everyone.